Good morning. Hopefully now you can all hear us. We'll just give it a couple more minutes, just in case there's anybody still to join, and then we'll get started. But thank you for joining us this morning.
John, I know it's only us on screen and I know people are listening. Can I just take a photograph of the screen so I can put it on my Instagram? Do you mind? Do you not mind being on it?
Of course you can. Of course you
can. Do you wish you'd shaved now?
Definitely.
Do it that way. Thank you. Do that after.
Perfect. Well, I think we'll get started. Hello and welcome, everyone. We're so pleased that you could join us for this special webinar series, exploring different aspects of the menopause journey. This is the first of 5 sessions that we're running through October. They're all standalone, but the more that you can come to, the better. Will be greatly received. And these sessions have been made possible thanks to the incredible cooperation of library services and NHS services across the northwest of England. And when libraries come together, amazing things can happen. And this series is going to be the perfect example of that. And while we're on, I'd love to encourage you to make the most of your local library service, whether it's for health information, community support, or simply a quiet space to reflect. Your library is there for you, and it is more powerful than you think. A huge thank you also to Libraries Connected, whose generous funding has made these sessions possible. Their support has allowed us to bring expert voices and valuable insights directly to you. If you have any questions during or after the session, you can always get in contact with your local library who can forward them on. So we'd love to hear from you. And let's begin with our first session. Perimenopause and menopause can be a confusing time, and navigating this journey can be tricky. We're delighted to welcome Dr. Cath Munro, a British Menopause Society menopause specialist. Dr. Munro will guide us through what to expect, how to prepare, and how best to navigate your own unique journey through perimenopause and menopause. So to get me off the screen now, and without further ado, I'll hand over to Dr. Munro.
Thank you very much, John, and thank you so much for inviting me to do this talk today. I'm just going to take myself off screen because at the moment all I can see is me, and I'm sure that's all everyone else can see. And hopefully I will be able to get onto presentation mode. John, I'm going to need to tell you, I'm going to need you to tell me if everyone can see that.
That is showing on my screen as being in presenter mode.
Perfect.
So yes.
I don't know if there's a way, if John, if you can tell me if it seems like I'm talking for ages and the slides aren't moving on. They probably are to me, so if you can let me know as well if that happens. And also, John, keep me to time as well, because I can have a habit of rabbiting on. But anyway, with all those things said, thank you so much for inviting me to talk. I am so privileged as a girl, grown up, born and bred in the Northwest, to have been invited to do this. The Northwest is a very, very special place to me. All my family live in and around West Lancs. I live in South Cumbria. And if Ormsgate Library's on, I think John said it might be, then big shout out, that's where I grew up. Anyway, so a bit more about me. Cath Munro. I trained as a doctor in Manchester. Trained as a GP in Manchester, worked in Stockport for a long time and moved up to Kendal for the country life in 2022. I have been working with our ICB over since then to try and build some direction with the women's health strategy, supporting them and our women's health champion to do some of that work. And I'm also, as John said, a British Menopause Society menopause specialist. There are currently no NHS menopause services up in South Cumbria, or very much in Lancashire, actually, for that matter, but I won't get onto my soapbox about that. And so at the moment, when I'm not doing my general practice work, I work as a menopause specialist in Menopause Care Limited. Just to say, John was just telling me about the other presentations that are going to be on through the month of October, and there's some fabulous ones. I know a few of the speakers, and there are others that I know of, but pelvic floor, bone health, nutrition, mindfulness, and I've just heard Diane Danzebrink's coming to do a talk about her book, which will be absolutely fabulous. So the more of those you can join, the better. Anyway, I will get on with my talk. As John said, I'm going to be talking a bit about perimenopause and menopause, hopefully trying to help you understand a bit about hormones, what they do and what they stop doing through perimenopause and menopause, what that might feel like, what kind of things you can do about it. And I guess there's a couple of points in the presentation where I'm very aware that I will talk about stuff that others will talk about in the future. I'll do it in a bit of detail, hopefully whet your appetite for the future presentations that come. So what to expect? Well, it's Menopause Awareness Month, October. So we're going to talk about hormones and just have a brief journey through what our hormones do when we have periods, and then what happens through perimenopause and into menopause, the kind of symptoms and what to expect. Approaches to taking control in perimenopause and menopause. And what I mean by that is it can be, I don't want to make it sound terrible for everybody. It can be a really tricky time, but there are always bits that we can do to try and move things forward on top of HRT, which doesn't work for everybody. So I'll give some information about HRT as well and touch on some other bits, and hopefully it will be a useful 45 minutes or so, probably coming close to 11:30 when we finish. So, always like a few pictures. You'll see a few more through the talk. What is menopause? Well, actually, menopause is just one day, and it's the day a year after your last period. So it's a retrospective diagnosis almost. You only know after the event and a year after the event. Meno equals monthly and pause equals stop. So menopause means stopping the monthly cycle, essentially. There's a period before menopause called perimenopause, which on average lasts 5 to 7 years, and probably for most people that's the rockiest time. I'll come to some other slides that give us a bit more kind of information on that really, but it's often the rockiest time before things start to settle down. And in just terms of a few bits of information to go around that, so the average age of menopause is 51. We diagnose something called early menopause if your menopause is between 40 and 45. It's normal to expect we don't need to test for menopause beyond the age of 45, but early menopause it's important to know about, and we'll come back to that. And premature ovarian insufficiency is what we diagnose with women experiencing menopause under the age of 40, and that is more common than we would probably think. So 1 in 100 women under 40 and 1 in 1,000 women under 30 will experience that premature ovarian insufficiency. And I will come back to that because there's some specific important things around that. And I think one of the things that I hear regularly is, oh, I've been told that I'm too young to be menopausal. And that might be for somebody in their 30s or even in their early 40s. And that's because I think as doctors and a lot of clinicians, actually, we've been ingrained with over 45, you don't need to test for it. You just expect you to be perimenopausal or menopausal. But under 45, if you're still having periods, it can be a bit more of a battle to be heard around, I think I'm in perimenopause. And hopefully I'll give you a bit of information to help you kind of navigate those consultations with clinicians that you might be seeing about that, but hopefully give you a bit of reassurance that you're not going crazy, that the symptoms that you're experiencing, if you are that bit younger, are probably still perimenopause, although it's also worth standing back and thinking what else it could be, which again we'll come back to. My pictures, I guess for some people, perimenopause and menopause is a straight road with a sunny end. That's Cat Bells up near Keswick, if anybody recognises it or wonders. The top one, that is. For other people, it can be a really windy path, ups and downs, kind of you think you're sorted and then you're not, etc., etc. And then the falling off a cliff analogy, it's how people tend to, if people come to me after they've had a hysterectomy or they've had another kind of medically induced menopause, the symptoms that people experience are that falling off the cliff type. One day you've got your hormones and next you haven't, and boy, is that a significant experience. Your body kind of goes through a big processing period then to be able to manage that change. And so it's just worth knowing, you might talk to somebody, or your mum might say, oh, I breeze through menopause, or your friends might say, well, I've not got much symptoms. Everybody's different, and everybody's journey is different. And I do like to think about it as a journey. I think the other thing to say is that we all have a finite day when we start our periods. We all have that day a year after our last period when we are officially menopausal and then postmenopausal. But in that period in between, things change gradually. So actually, I don't think I've got the slide in here, but there's if the average age of menopause is 51 and perimenopause lasts 5 to 7 years, if the average age of menopause is 51, that means it's completely normal to be menopausal at 45. And if perimenopause lasts 5 to 7 years, then it isn't unusual to be experiencing some perimenopause symptoms in your late 30s. And that doesn't mean everyone needs HRT in their late 30s. It just means you can have period changes and other things, which we will come to in future slides. So what hormones are we talking about? Because I'm guessing not everybody really knows. And apologies, this is a diagram that I probably never understood through medical school, so I'm not expecting people to grasp the full detail of it. But I guess the important bits of this are, this is an illustration representing a month, so a period, a 28-day cycle if you'd had 28-day cycles of periods or whatever, day one to your period start, so your period starting to the next period starting. And within that month, when you're having periods, there's what's called the follicular phase and the luteal phase. And the follicular phase is the first half of the cycle, and you've got lots of hormone activity with various different hormones that are stimulating an egg to be produced. Actually, several eggs are produced, but one becomes a dominant one. Mid-cycle, lots of hormones surge, and that's often associated with a feeling of well-being. Your ovary releases one egg. And then what's left behind is this thing called the corpus luteum, which produces progesterone. So you don't have progesterone in the first half of your cycle, you only have it in the second half of your cycle. And then towards your period, the thing that creates the bleeding is that drop in hormones, which you'll see with the green curve of progesterone dropping down. That's when you start to bleed. And we could talk a lot more about that, but that's for a different time. It's just to say that's what's happening. And that will kind of be relevant as we go through talking about HRT and the way that works and the way it's prescribed. What's going on at the bottom there, the endometrial cycle, is, as you can see, that first bit is that the period, the shedding of the lining of the womb, and then it slowly builds up, particularly in that second half of the cycle under the influence of progesterone. And as I said, that drop in progesterone is the thing that makes you bleed. If you translate one bump of the premenopause bit here, so you see a couple of green spikes, a dotty spike of luteinizing hormone, and then that progesterone curve, each of those in the premenopause bit of this chart indicates 1 month, so one of those from the previous diagram. In premenopause or in your normal menstrual cycle, if you're not on contraception, if you haven't got other conditions that are causing it, there's a very rhythmic monthly beat to our bodies that we normally all will get some sense of, oh yeah, I understand my own rhythm. I can kind of expect what's going to happen, understand what's going to happen and when. And as I said before, perimenopause can be quite bumpy. And as you'll see here, and I don't know if you can see me, but I'll do it anyway, the hormones become a bit more like a roller coaster. There are ups, there are downs, there are peaks, there are double peaks in hormones, particularly estrogen. And all of those things can make it so high estrogen and low estrogen can both cause problems, as can the changes in progesterone through the cycle. So perimenopause becomes bumpy. And then what happens, as you can see, if you look at the green line and the not dotty line, the complete line, those hormones kind of drop down and become quite level. And that's what I was saying before, perimenopause tends to be the bumpiest time. Once you're in menopause, those hormones are level and things tend to feel a bit better. The only other thing to say on that chart, and we will come back to it, is that the kind of the paler blue kind of turquoisey aqua dotty line is the thing that we check to check if you're menopausal. So if you go to the doctor and say, can I have a blood test for menopause? Quite often they'll say, no, you don't need one. But if you're under 45, and we'll come back to that later, it's that dotted line that we're checking. And as you can see in perimenopause, that's all over the place. So it might be normal one day and abnormal the next, or it might be normal in the morning and abnormal in an afternoon. So it's unpredictable in perimenopause. So if you've got symptoms, which again we'll come back to, you go to the doctors, you have that test and it's normal, but you still feel like you've got the symptoms. The likelihood is you are perimenopausal, you're not too young. Again, taking it in that broader context of other things that can happen too. So what might happen? This feels a bit busy, this slide. What might happen in perimenopause? Well, 1 in 4 women don't experience many symptoms at all, other than period changes, which is obviously the main bit of what's going on that we experience other than symptoms. So sometimes in your 30s, maybe mid-30s, later 30s, depending on when your menopause is going to be, you might notice that your periods aren't as predictable as they have been in the past. So they might be a bit lighter, they might be a bit heavier, they might be more or less frequent, they might be more painful actually. And then the other thing that might happen alongside that is that you have a change in your premenstrual symptoms. So you might notice that you've never had PMS symptoms before, but suddenly you start to feel more moody. You might get that rage that some people describe. You might get sleep disturbance. You might get sweaty at night. And it might only be in those few days before your period starts. And there'll be other times in your monthly cycle where you feel absolutely fine. And I'll often see people that say, oh, I booked an appointment and I felt terrible, but I feel a fraud now because I feel fine today. And that's really, really typical of perimenopause. The symptoms can vary month by month, week by week, day by day, and hour by hour. So, and it often feels people will say, am I going mad? You know, what is going on? It's all very typical of our perimenopause journey. And apologies, this chart comes out a little bit blurry, but it's more to make a point really that, so what are the symptoms of perimenopause and menopause? Well, we've got estrogen receptors from the top of our heads to the tip of our toes. And so it's not unusual or it's not unexpected to therefore experience symptoms from the top of our heads to the tip of our toes. And not everyone gets everything, but people will get a mishmash and it will change over time. So just to name a few things off there, common things that I see: anxiety and depression, really common. Never had it before, or maybe had a bit of anxiety early in life, but that's got worse. Brain fog, hot flushes are the main thing. If you listen to a lot of things on social media, or if you listen to things from menopause specialists, we'll often talk about the fact that hot flushes are probably where the evidence for benefit of HRT sits more than anything else. But that we are more than hot flushes and our experience can be much more. So mood swings, hair loss, irritability, fatigue, itchiness, like you can't describe, something called something called formication, which feels like ants crawling under your skin. Well, what else have we got? Bloating, digestive problems, urinary symptoms, which we will come back to, tingling symptoms, vaginal dryness, all sorts of it. Osteoporosis, again, we'll come back to. And I think the symptoms are really important to know about. I guess it's where the impact of those affects you. That's the thing that is what we need to gear our any treatment towards. So if you've got, you know, the odd hot flush, feeling a bit bloated, but otherwise you're functioning fine, you don't necessarily need to do anything about that. It's when it becomes limiting to your daily functioning, which it commonly can, that things can that we find that HRT can help, or other treatments. And I guess the only other thing on there, headaches and migraines. If you're a migraine sufferer, you can go, maybe you've had migraines in your teens when your hormones have started to change, been fine through your 20s and 30s, and suddenly you start with migraines again in your 40s. That is really common. And again, a symptom of those fluctuating hormones. So all of those things can be kind of symptoms suggestive of menopause. I guess the only other thing to say is there's a lot of crossover of these symptoms with other things as well. So if I'm seeing somebody at 38 with some of these symptoms, I'll be thinking, well, what else could it be? Looking at things like vitamin levels, B12, vitamin D, iron, blood count, sleep, well-being, all of those things as well can either worsen these symptoms or mimic these symptoms. And I guess the other thing, the reason I put this slide came up in a presentation at the British Menopause Society conference this year, and I'm so glad it's come out clearly because I wasn't sure it would. But I guess what that's saying is if naught in the middle is your menopause, then either side of that is giving you 4 years before and 4 years after. And what it's saying, I guess it's to give us all hope that not all symptoms last forever. So those brain fog and sleepiness symptoms will potentially be really bad in perimenopause, but there's a general trend of improvement once you get past menopause. Hot flushes as well can be worse around the time of menopause, but again, will start to settle down. And then I guess the one thing to highlight, and that there could be other things on here as well, but in terms of common symptoms, genitourinary symptoms of menopause, so sexual and urogenital alterations, what that means is things like dryness, irritation, soreness, discomfort on intercourse, urinary symptoms, infections. Those are the things that don't go away, and we need to have a plan for those. Again, everybody's different, not everybody needs the same approach, but it's really important to know that there are options to manage those symptoms. I will come back to it because it's one of my big soapbox things. None of us should be suffering with significant down below symptoms. We should feel free to talk about it, and we should seek treatments for that. Moving on, so what blood tests are needed to diagnose menopause? Well, officially none. As I said, if you're over 45 and you go to the doctors asking for a blood test, the answer is you don't really need one, because if you've got symptoms of menopause, likelihood is you are in perimenopause, and so you don't need to do anything else. If your periods have stopped, it's much more clear, but if you're in that kind of, your periods are changing, you've got symptoms, you don't necessarily need a blood test. But if you have a blood test, it's that turquoise dotted line that I talked about before, that FSH. We sometimes only test it once now, but officially 2 blood tests 6 weeks apart, and that's to try and catch that level at different times in the cycle. And if that's raised, then we can go on to diagnose, in inverted commas, menopause. It can be useful over 45 if you've got a hormone coil, to know when that hormone coil can come out if you're not using it for HRT. And if you're using other contraception, it can be useful to know when that blood test is high and when it stays high, to know when you can stop contraception. If you don't have that blood test done, we work on the principle that everybody should have use contraception until the age of 55 to avoid that little surprise, that little bundle of joy arriving at 51, 52, 53, unless you're planning it. So yeah, blood tests in general, over 45 you don't need, apart from in those specific circumstances. But as I said, I think before, because it's variable, we can't use it to diagnose perimenopause. And it is a frustration for a lot of people going to the doctors, having the blood test, being told it's normal, being sent away saying, oh, it's not menopause. If you've got those symptoms, as I said before, it's the symptoms that we should be working to. Blood tests can be helpful for other symptoms. As I said, it's that standing back and checking what else it could be that might be causing symptoms and mimicking them. But again, the best way to diagnose, for me as a clinician, to diagnose perimenopause or menopause is to listen to the symptoms that somebody's describing. And the best way to decide what treatment is needed is based on the impact of those symptoms. Just a couple of other things that you'll remember on the chart of what's the roller coaster bit of perimenopause, and then things drop down. We've talked already about genitourinary syndrome of menopause, but just to highlight again, when your estrogen level is low over time, that will a lack of estrogen in the pelvis will potentially cause some pelvic floor weakness, which can cause urinary and fecal incontinence, so leakage, irritation, so dryness, soreness. You might notice you go for a cervical screen and it's painful where it never has been before, or you might notice on intercourse that you've got pain and discomfort that you've never experienced before. And urinary symptoms, so increasing frequency, feelings of not emptying properly, urinary infections that you've not had before, all of those things become more common as we go post-menopause into our 60s, 70s, 80s and beyond. It's one of those things that if there was a way to give it to everybody, more or less, I think I'd be doing it, putting it in the water if there was a way of doing that, but we can't. Anyway, other things that happen, our bone density, there's a chart that I'm going to show you in a second, which shows how our bone density changes over time. When our estrogen levels drop in perimenopause and menopause, our bone density drops, and that means that we have an increased risk of fracture. I'll come back to it in a sec. You'll also potentially notice changes in weight, particularly around perimenopause. I get a lot of people suddenly, I'm doing exactly what I did 5 years ago to lose weight, and the weight's not shifting. And we'll come back to that briefly. But I know there's a talk. There are several talks, and in fact, I'll be part of one of them on nutrition at the end of the month, where we talk a bit more about strategies for managing health and hopefully optimizing weight around perimenopause and menopause. Our cholesterol levels change a bit around under the influence of a lack of estrogen, and we get an increased risk of heart disease. So again, we will come back to that in a sec. Bone health wise, I hope everyone's keeping up with this, and it is recorded, so you'll be able to watch it back. I'm conscious it is a bit of a whistle-stop tour. Bone health, really, really important to think about for all sorts of reasons. You'll see that our bone density, well, we have men and women on this curve. For all of us, we achieve a peak bone density around our mid-20s. You'll see that women's peak bone density is generally lower than men's. And men's from our kind of 30 or so tends to start to drop off then as we get older. You'll notice there's a different shape to the pink curve. So for women, and you'll notice that the age that there's that little drop off is around between 45 and 60. So in perimenopause, our bone density will drop by up to 20%, 25%, and then continue on that slow reduction over that. I'll let that hang there. Estrogen in the form of HRT can help kind of stop the drop and hold the bone density, but there's lots of other things we can be doing as well. So I don't for 1 minute want to suggest that it's all about HRT. We will come back to it. I guess the other thing to think about here is actually that the peak bone density that we achieve is influenced by what we do in our teens and 20s. So for instance, if I know Angela White, when she talks about bone health, we'll talk about this, activity levels in teenage girls. If girls are inactive and with not particularly healthy diet, they will not reach their peak bone density. And similarly, if women take, or if girls, teenagers use depot contraception, so the intramuscular 3-monthly injection, that can influence that initial bone density that's achieved. So then you enter your peak bone density lower and will drop it sooner. And I think the only other thing to say about this chart is that if you're looking at the kind of 70 plus bit of here, a bit of this chart, 1 in 2 women will get an osteoporotic fracture in their lifetime. 1 in 5 men. And you can see why that difference in bone density change over time. Men can experience osteoporosis, 1 in 5 will, but yeah, it's women that tend to get the bigger impact, and that's why I am very passionate about it, and Angela is even more passionate. And I want to highlight that midlife change is not just about hormones, and it's not all solved by HRT. And for anybody that ever consults with me, I talk about jigsaw puzzle pieces a lot. In our jigsaw of what brings us to experience what we experience is the stress that we experience, our lifestyle, our nutrition, and all of those things come together to be what we experience on a day-to-day basis. And in terms of solutions to how we feel, we can do things about all of those things, potentially. Sometimes some are more difficult than others. And sometimes we do need the helping hand of HRT to help us feel better so that we can start to tackle other things. But HRT is a jigsaw piece in the puzzle. For some people, it's a huge piece. For other people, it's a very small piece. And for some, it's just not a piece at all for different kinds of reasons, which again, we'll come back to. So although I am going to speak a little bit in a few slides time about HRT, I guess it's just, again, this kind of refers to the talks that are coming through the month. What can I do now to help my future? And I like to think about this. I've only this year started going to the gym and doing strength training because everyone kept telling me it was a good thing to do in midlife. And so I thought I would practice what I preach. And every time I lift a weight, and particularly if I progress in a heaviness of a weight, I feel like it's money in the bank. Not for now, but for well, it is for now, but in 5, 10, 15, 20 years, if I'm doing strength training that helps me sit up and get out of a chair, it helps me lift the shopping, it helps me kind of correct myself if I trip, all those things are kind of insurance policies for my future. And I really urge people to think a bit more about that and what they can be doing, what you can be doing to invest in your future from a fitness and health perspective. Think about your bones and muscles. Again, that's going to be a talk later in the month. Think about your pelvic floor and urinary system. And if you're experiencing symptoms, go to the doctors and talk about it. Don't sit in silence. Don't suffer when there are things that we can do about it. Also, fitness and nutrition, which again, there's a talk later in the month, but also think about, you know, your heart health, your brain health, your falls prevention stuff. We will come back to a bit of, and what else can I do? But we'll just move into a bit on HRT, if that's okay. So the HRT jigsaw puzzle piece. HRT, or menopause hormone therapy. I was listening to a talk on a podcast from Stacey Sims the other day saying that she doesn't like the term HRT. My personal view is it's splitting hairs. I think there are some people that think, well, your hormones are dropping naturally and therefore it's not replacing hormones because they're hormones that in perimenopause and menopause, or particularly in menopause, our bodies are not designed to have them, but we are replacing hormones at the same time. So as I say, splitting hairs, but menopause hormone therapy, a different term for it. It's the American term and probably the European term as well. So if you are online or on social media or reading stuff around menopause, you might see HRT, you might see MHT. They're the most common things. And what is HRT? Well, principally estrogen and progesterone. And if you think back to that kind of the pre-menopause, perimenopause and menopause chart that I showed you earlier, it's what we're trying to do is with estrogen, minimize the big drops in estrogen. Whenever you have estrogen, you need progesterone, and we'll come back to that shortly. And then testosterone is, some might say, the third hormone. It is a hormone that we can replace as part of HRT. Although a lot of GPs can't prescribe it, it is part of the toolkit that some people might find beneficial. Again, we will come back to it. So a bit more about HRT, and we'll just spend a few minutes on this slide. We've got some pictures of some of the things that you might be prescribed, that you might see, actually, I haven't got any tablets on here, but I'll go through the kind of the kind of basics of HRT and then perhaps come back to the pictures. So when people have HRT, if you've still got a womb, you will need estrogen and progesterone. But if you've had a hysterectomy, then you can have estrogen only HRT. And there's a few slides time. There's an illustration that I'll show you on why that's relevant. Estrogen, well, any HRT you can have as tablets, and then estrogen's available as patches, for instance, the Everel Sequi on the slide, gels such as the bottle that's at the top, the estrogel, and the spray, which is the brown and white box at the bottom with something that looks, I don't know what it looks like a speaker of some kind. That's a spray of something called Lenzetto. Each of those are so there are, if it was Everel and Everel Sequi, that would be an estrogen only patch. So you can have a patch, a gel, or a spray if you've had a hysterectomy. If you still have your womb, you always need estrogen and progesterone. And there are different ways to do that. Everel Sequi is a combined patch, so estrogen and one of the progesterones called norethistérone. There are tablets as well that are a combined way to do things. One of those is, for example, Femiston is a combined HRT tablet. When somebody's in perimenopause, and if you imagine that, again, those hormones going all over the place, if we put everybody onto a continuous dose of progesterone alongside their estrogen, likelihood is that they would bleed. And that's because the HRT that we're prescribing is battling your own hormones. But ultimately, we want everybody to go onto a continuous dose of HRT. So if your periods are going a bit funny, you've got symptoms of perimenopause and they're really affecting you, then you'll be prescribed something like the combined patch Everel Sequi, or you might be prescribed estrogen and that thing Utrogestan, the box in the corner, which is the thing you may have heard of, micronized progesterone, body identical progesterone. So that can be taken cyclically in the month, 2 of those capsules for 2 weeks out of 4, or you take those sequential patches, which have different things in them, the 2 weeks of the month and the second 2 weeks of the month. We would always aim for everybody to be on a continuous dose of HRT by about 5 years of being on their HRT, if they're continuing it that long. And that's because we want to give people wound protection every day, ultimately, and that Utrogestan needs to be something that's in your system every day, but at a point where it doesn't create bleeding and troublesome problems. The other way to have HRT is with estrogen, like the patch, the gel, or the spray, with the Mirena coil, and that little T-shaped thing inside a pink thing is a Mirena coil in a womb. It's brilliant. Menopause specialists love it. It's the thing that manages bleeding more better than anything else, ultimately. And it serves as contraceptive. And if you need contraception to 55, it's an easy way to have that. So it controls your bleeding. It can be the progesterone bit of HRT, and it's contraceptive. So it's win-win. With their periods, sometimes in perimenopause, having estrogen can really make you feel horrible, because you get higher levels of estrogen at times in your cycle. So sometimes what you want to do is flatten that menopause and then continuous once you are in menopause or you've been established on HRT for a while. I'm just coming out of my presentation for a second to check that everybody's where I think they are. Are we good, John?
You were just freezing up for me a little bit on the screen then.
Okay, all right. It's just I was getting a bit of as if somebody was trying to ring me in the background, and I didn't know if it was you trying to contact me. So are we good so far? Is everything okay?
It appears to be for me. As I say, you just froze up for about a minute a moment ago, and we lost
Okay.
I lost the last little bit that you said.
On the previous slide, the HRT slide.
Yeah, on the HRT
right.
slide.
Well,
yeah.
I will go back to that one. Hang on 1 minute to just do a bit of a summary, because I'm aware it is from, hang on a minute, from current slide. And John, if you can just reassure me that I'm back on the slides.
Yep, it's back on now.
Yeah. Okay. So just to summarize this slide, because I think it's probably the most complicated one, and apologies if everyone's heard me say this once. If you've had a hysterectomy, you have estrogen and the HRT as patch, gel, or spray or tablet. If you still have your womb, you need progesterone. I can't emphasize that enough. And you need enough progesterone. It'd be continuous if you're in menopause, sequential if you're early in perimenopause. Mirena coil, brilliant. It gives you the flexibility to change your estrogen, to do different doses and things a bit more. And vaginal estrogen, as I was just saying, coming onto this slide, is safe for nearly all women. If women have had breast cancer as well, with the exception, it's a kind of semi-exception. For women on letrozole, there's one study that says that there's possibly an increased risk of recurrence of breast cancer coming back if they use vaginal estrogen, but it's a small study, and there's a lot of talk in the menopause community at the moment about actually, is it a reason that people can't have vaginal estrogen or not? Because vaginal symptoms can make people feel really miserable. If you've had them, you'll know what I mean. Yeah, so there are different kinds of vaginal estrogen. Probably the most common one I prescribe is Vagirux, which is the little thing down there with an applicator and little tablets that you insert into the vagina. There's the estriol cream, which people use with an applicator inside, or you can just apply externally. And sometimes people use the Vagirux inside and the cream on the outside. And for slightly older ladies who've perhaps not had estrogen since menopause and have got really quite significant symptoms down below, perhaps with water infections or leakage, Invagis is one of the options for, it's a slightly lower dose, it's slightly gentler. That little torpedo thing there melts in the vagina and releases estrogen locally and can be really helpful. And yeah, just remember that you don't need to experience the symptoms of perimenopause and menopause down below. Go and talk to somebody about it. I know when you have the pelvic floor talk at some point this month, you'll get loads more information about this. But vaginal estrogen is brilliant, and vaginal moisturizer is also important. I always say treat your down below bits like you treat your face. You moisturize your face probably every day. You don't need to put makeup down below actually, but you put moisturizer down on your face. So you can buy vaginal moisturizers, or you can use the very plain moisturizers like Aveeno and things like that down below, just on the external parts. And it can sometimes make the world of difference if you're getting chafing and soreness and irritation. So combine the vaginal estrogens with vaginal moisturizers, which aren't estrogen based. There's one called Yes. There's another one called Dr. Wolf's VSAN. There are other ones that you can buy. Avoid things with perfume in, avoid soaps, avoid wipes if you can. Just go for the moisturizer on the outside and the vaginal estrogen, and that will usually improve symptoms exponentially and make things feel way more comfortable down there for whether it's sex, just day to day, sitting down, all those things. It will make a difference, I promise. So who needs to take HRT? The British Menopause Society says HRT should be used to treat the symptoms of menopause. And as I said before, it's the symptoms, but also the impact of the symptoms that we need to be thinking about. Who actually does need to take HRT, if you've experienced menopause under the age of 40, the recommendation is to use HRT until the average age of menopause. And it includes women who are at higher risk of breast cancer, even with maybe with the BRCA gene, which some people might know about, and maybe have had some surgery to reduce their risk of developing cancer. Because their risk of breast cancer is so much lower, but their risk of other things is higher, that the general advice is that the benefits of HRT far outweigh any risks up until the average age of menopause. As I said, anyone who's experienced symptoms which are impacting their day-to-day life, really important to have HRT, or it can be part of that jigsaw puzzle. But HRT can help in other ways as well. So it can prevent a drop in bone density, which we've talked about. If you start HRT within 10 years of menopause and under the age of 60, it reduces your risk of heart attack and stroke as you get older. It can also support brain health. I won't say more than that, other than it certainly helps from a blood vessel perspective. It might help in other ways, but there are still studies that conflict each other. So there's not enough evidence to say that it reduces the risk of Alzheimer's. What we do know is that women that experience a very early menopause and don't have HRT have an increased risk of dementia in their future, as well as an increased risk of osteoporosis, which is why it's so important to have those extra hormones from premature menopause to the average age of menopause. I mentioned this slide before, just in terms of breast cancer risk and estrogen only versus combined HRT. And essentially, over the age of 50, the risk of breast cancer is about 1 in 7 in the population. If you have estrogen only HRT because you've had a hysterectomy, those green people on that slide for estrogen only HRT is a reduced risk of breast cancer. So it's not estrogen that causes the problem with breast cancer. When you combine estrogen with progesterone, it increases the risk, but only slightly. And it depends on the kind of progesterone you had. I talked before about Utrogestan and about the Mirena coil. I've also mentioned northisterone, and each of those has a different risk. But the micronized progesterone and the Mirena are considered to be more of a neutral effect on breast cancer risk, we think. I think the second half of the slide is really important, because what it highlights is that if you're active, if you exercise, and depends what you interpret with exercise, but moderate exercise through the week, 2.5 hours or more, then that reduces your risk significantly of breast cancer, as does not smoking, drinking within the normal recommended limits of alcohol. And if you have a higher BMI, over 30, that does double your risk of breast cancer. And I normally share that with people because I think, one, to say HRT doesn't turn a normal breast cell into a cancer cell, but it can increase the rate of growth of things. And you can manage your risk in other ways. You might need HRT to feel better so that you can increase your activity levels and start to think about managing your weight. But all of that together, I think, gives us there's a real mandate for each of us to think about what we can do above and beyond HRT to manage not just breast cancer risk, but cardiovascular risk, and just age well. Just to say, when HRT is not the right option, so breast cancer, women that have had breast cancer in the past, it's not completely disallowed to have HRT, but it needs a conversation with a menopause specialist and also with the cancer and oncology specialist that you will have been treated by. There are some other cancers that might need some specialist consideration, and most menopause specialists would be aware of that. Quite a lot of people have been told they can't have HRT for a number of different reasons, whether it perhaps you've had clots on the lungs, but most people can have estrogen through the skin in that situation, although it might need a conversation with a specialist again. Women that have had migraines are told that they can't have HRT. Again, they can through the skin, and normally there's a bit of tweaking, but we can get there to a dose that controls migraine. And essentially, I guess the summary point from this slide is that most women can have HRT if they choose and want to try it. It's also worth saying that HRT isn't always straightforward. There are side effects which are common and not to be surprised by. So irregular bleeding can be an issue, bloating can be an issue, breast tenderness can be an issue, headaches can sometimes be an issue. And I think it's always if you look on social media, there is a bit of a HRT solves everything. It definitely doesn't for a lot of people. And I think we've probably falsely built hope on that over the last few years in social media circles, but it can be really helpful. And most of those side effects are things that we can manage. So breast tenderness, there's something you can take called starflower oil, which is in a capsule that you can buy that can really help reduce breast tenderness, as can evening primrose oil, but you need bigger doses of that. Bloating will normally settle over time, and bleeding will normally settle over time. It just takes a bit of perseverance to get there. But it's just worth knowing, if you're embarking on HRT, that it's not the panacea, and it doesn't suddenly make you feel fabulous and in the way that sometimes it might be presented on social media. Role of testosterone, I'm looking at time. We've still got a little bit more time left. I'm aware we might not have loads of time for questions, but testosterone, British Menopause Society says it's to be used for very low libido, and there's a specific thing called hyposexual desire disorder that your clinician might ask you to fill in a questionnaire about. It can sometimes be helpful as well if women are on higher doses of estrogen to avoid having to go on even higher doses if they've still got symptoms. Testosterone can be helpful for energy levels, muscle aches and pains, mood. It's not yet available on the NHS. There is a preparation that has gone through the process of being licensed, but it's still not available. But you can get it through a menopause specialist. And at some point, because we have a shared care arrangement, your GP might be able to prescribe it, but in Lancashire and South Cumbria, we will need some kind of clinical pathway to enable that to happen. So a lot of GPs won't prescribe testosterone at the moment. Precautions with testosterone: it needs a blood test at 8 to 10 weeks after you start it, and then an annual monitoring. It can give side effects. Again, it's not the wonder drug that is sometimes presented as. In my experience, about half of women stop it, either because they don't really get any improvement, or because they get symptoms like greasy skin and acne, or probably more distressing hair loss from your head or hair growth in places you don't want hair. All of that is reversible when you come off it, unless you've been on super high doses, which is why we monitor the blood test to avoid that happening. Other options, because it's always worth knowing, there's a multitude. I'm sure we'll all have seen the counters in the chemist or the health food shops, or I get bombarded anyway on Instagram with different things that are the next wonder drug. Different people find different things helpful. My best advice is don't spend a fortune, don't get lost in social media messaging. Find something that works for you. Don't spend inordinate amounts of money, because it probably won't work any better than the thing that costs £3.50 in Boots. But black cohosh, red clover, sage, magnesium, ashwagandha, lion's mane are all things that pop up regularly on my social media. Some of those have some evidence of benefit. Some of them don't, but if you find it helpful, it's probably not going to do you any harm, with the caveat that if you are on some breast cancer medications, some of those have a hormonal base to them. So red clover particularly needs to be avoided if you're on breast cancer medications like tamoxifen and letrozole. Alternative prescriptions, so things that I might prescribe as a GP. Some antidepressants are recognised as being valuable in the treatment of symptoms of menopause, some pain medications, and then a few other tablets that can help sweats. There are new medications coming for sweats. They're not yet available on the NHS, but I think it's a watch this space. I'm sure it'll be in the next 6 months that we can start to prescribe those, perhaps with a bit of clinical supervision from, again, from a menopause specialist. How to approach your appointment with your GP. Go prepared. It's deliberately blurred, the table, but basically it's saying use symptom trackers and symptom questionnaires can be really helpful to get your mind in order of tick and prioritize how much of a bother are the symptoms I'm experiencing. You can find symptom trackers through the Balance app. If you Google menopause symptom tracker, you'll find things online as well. They're just a useful tool to take with you to underline these are the things I'm experiencing, but go with what are the impacts on my life. As GPs, we're trained to ask people to explore the impacts of things, and it's hard to argue against somebody saying I've got these symptoms and I can't get out of bed, or I'm not getting to work, or I've stopped being able to drive the car because I feel so anxious, or a multitude of other things. These things are bothering me. I can't sleep. I can't function. I need something. So it just having that, where's the impact? And also, what are my priorities to sort? So if I've got 5 symptoms, brain fog, fatigue, night sweats, sleep, mood, what's the thing that's most troublesome for me? And if I could only sort one of them, which would it be? That's always a good thing. What have I tried already? What do I think I need from my GP? And what can I do for myself? I think it's worth having that conversation, going back to things like bone health and heart health and smoking and alcohol and all those things. What else can I do for myself? I think it's a really motivating way to think about things, particularly if you've got a GP that's listening and being helpful alongside that. So if you smoke, stop. If you drink alcohol, drink within the recommended guidelines. I think in my experience, a lot of women in perimenopause actually reduce their alcohol intake because it makes you feel rubbish. Others will use it to manage stress or anxiety symptoms. And I would recommend, if that's you, getting to your doctor to talk about those symptoms and what you're doing and how you could manage those differently. Be active. Less about calories in, calories out in midlife. And as I said earlier, what once worked often stops working. But think about the kind of activity you enjoy, because that's usually the thing that you'll stick to. Walking, jogging, running, swimming, cycling are all good for general fitness, but it's better if it's mixed with short bursts of higher intensity exercise. Yoga and Pilates are good for mindfulness, relaxation, posture and strength, kind of that isometric strength. But lifting weights and building muscle, excellent for bone strength, great for muscle strength. And if you remember the piggy bank before, great for money in the bank for the future. But you may need to feel better, perhaps with HRT, before embarking on some of those changing. It can be really overwhelming to think, where the heck do I start here? And that's where a good GP will help you work through that. So in summary, hopefully that's not been too much to take in, and hopefully you'll all watch the recording back and stick on the slides that you find the most useful. Track your periods and know where you're at with them. Track your symptoms, know where you're at with those, and think about what impact it's having and be able to articulate that to your doctor. Think about the solutions like pieces of a jigsaw puzzle, and don't rely on one thing to be the only thing that'll work. What can I change? Start small. If it's exercise snacks is the new big thing. 10 minutes a day rather than going to the gym and doing an hour, having a few bits of kit at home. I'm sure Angela will talk about this, and certainly me and Rini might come back to it at the end of the month. Exercise snacking to do bits of strength stuff, running up and down the stairs or walking up and down the stairs 10 times, various bits. You can start small and build up. And where do I need help, and who do I get that from? Because it might not just be the doctor, it might not be the practice, it might be somebody in your community. And again, if you don't get what you need from your GP, seek further opinions and advice. Remember, there are different perspectives. I put We Do Not Care community. I don't know if anyone looks at this on Instagram, but she's a very, very lovely and funny lady that has just given me a bit of a different perspective. I urge people to have a little look on that on Instagram for a bit of a light-hearted relief on perimenopause and menopause. think about menopause as a second spring. You know, we develop new wisdom as we go into our later life. We're not kind of the witch or the hag from the Disney films. You know, we can thrive and flourish and become that wiser head to other people, perhaps younger than us or in our communities. It's not all bad, and most symptoms do improve after menopause. But when you're in it, let's not pretend. It can feel absolutely dreadful. But share how you feel with others close to you, build community around you, and make sure you take time for yourself as well. Just a word on community, just because I'm proud of what we've done in Kendal and South Lakes. Anyone's free to join our South Lakes Menopause and Wellbeing Hub Facebook group if you're on Facebook. We run cafes alternate months in Kendal, and we do talks often on the months in between, all free, with some funding from our primary care network. So a little bit of money helps us with cafe hire and things. We do drumming, we do different activities on World Menopause Day on the 18th this month. We've got a whole load of things that we are advertising through the Facebook group. But it's just such a gem to talk in a group of women and share experiences. And it's surprising what people will share in those situations. That bottom right hand corner slide, that's me and Rini. Rini's doing the two of us are doing the talk at the end of the month. So you'll see us again if you join those future talks. And just a few resources to finish. Menopausecare.co.uk, that's the clinic that I work for, but there's a website. Naomi Potter has an Instagram, and she's the founder of Menopause Care. Because I don't want to make it all about menopause care, there's the Balance app, which can be really useful as well. ROS.org is the Royal Osteoporosis Society, with some really good information that I'm sure Angela will come back to. Women's Health Concern is the British Menopause Society public-facing website. Some really good stuff there. And the POGP, I'm not going to remember what that stands for at the minute, but it's the pelvic floor information. There's really, really, really good stuff on there. So that's some of the resources that I point people toward regularly. And there are many more that I'm sure people in future talks will also mention. And that's me. So thank you very much. I will exit the presentation, conscious of time. Apologies that I've run almost to the end of the time. Hopefully John's not going to shoot me. I will come back onto screen, and yeah, so here we are.
I would like to thank you, Dr. Munro, for an engaging and fascinating presentation. It's been very informative for me, at least. I hope for everybody else out there. And as I say, if there are any questions, the first point of contact would be your local library where you found this talk from. Alternatively, you can email me. My email address is culturaldevelopment@lancashire.gov.uk, and we'll look to answer some of those questions when we post the video, which we're hoping to do later in the year. Just a few dates for your diary. We have a few more sessions going over October. We have Mindfulness and Menopause Awareness on Thursday, the 16th of October from 12 noon until 1 p.m. We then have an Introduction to Bone Health for Perimenopause with Angela White on Tuesday, the 21st of October from 1 p.m. to 2 p.m. We then have Making Menopause Matter with the author Diane Danzebrink on Thursday, the 23rd of October from 1 p.m. to 2 p.m. And then finally, we have Staying Healthy in Midlife with Dr. Munro again and her colleague Rennie McGregor. And that will be on Tuesday, the 28th of October at 10:30 a.m. until 11:30 a.m. And I'd just like to thank you all for watching and for being here today. And yeah, wish you all the best for the rest of the week. Take care.